like to call upon our instructor, Dr. Misra.
Can I have
He's
the slides?
presently the director at Swanjyoti Eye Hospitals in Lucknow. Over to you, Dr. Devakant.
Can I have the slides, please? Yeah. So I'll be presenting a slight modification to the autologous retinal transplantation technique. So this was a very challenging case for us. She had already been operated several times.
With the
She
help
had
of
presented with, yeah. No, order. So she had already she was a macular hole case. She had already been operated twice elsewhere. Sorry. And then there was a failed macular hole case, and then she developed a total retinal detachment. Then she was operated for a retinal detachment with oil, and after silicone oil removal, there was again a redetachment in this case. So at that time, she landed to us. So there was redetachment with an open macular hole. So we planned a 4-port vitrectomy for her. This is the open macular hole. So I planned autologous retinal transplantation for this patient. Here you can see that I have prepared one site before, which I have abandoned because I thought the size was a bit smaller. So I've again gone for a larger graft, used an endocautery to prepare the graft site in this case. Now I've used a curved scissors to excise the graft. Alternatively, a cutter could also be used. Now what I've done is that I have not completely excised the graft at this stage. I'll just leave a stalk behind so that the graft is not free floating in the fluid. And I'll not be using a PFCL in this case because my previous attempts with PFCL have been a bit challenging. So I'll do a partial fluid air exchange. I'll not do a complete one. So this partial fluid will allow a limited space for the graft to move around in case it starts free floating in the fluid. So at this stage, I'll complete the FX and glide the graft over to the macular hole. Now slightly tuck the graft because my main concern is to anatomically close this place. Now I'll provide it some endolaser to the graft site, and I'll do a bimanual silicone oil injection where with the help of the closed ILM forceps I hold on to the graft because at times I've seen that with the gush of the silicone oil it starts moving around. Yeah, chandelier display. So now this is post-operative 1 week, the hyperreflective area. This is our graft, and after a month's time, we see a good foveal contour that is maintained in this case. The patient is maintaining around 636 vision and is still under oil. So that's the case. Compared to the other technique where we use PFCL, a lot of times we see, in my personal experience, while removing the PFCL, the graft gets sucked in. I've seen several cases where a lot of times people have to prepare other sites to do it. And this avoids that issue with this.
Half FA.
Yeah, a partial FA. And then, so I left a stalk behind. The graft is not completely excised at that point. So then in the partial FX, I remove the graft, let it be there, then complete my FX and then glide it over to the macular hole side.
And you're doing the FA through the macular hole?
No.
Just
normal. Yeah.
Okay.
Towards the disc.
So, Dr. Devakant, I think nicely done. I would want to emphasize a couple of things here. As you have said, there is this, when you have a PFCL there at times, so what actually happens is when you want to get into the interface of the PFCL from the fluid, that is where the problem happens. It kind of floats up, it doesn't go. So that is one good technique where you said that putting it as a partially FX thing done, you can easily glide you can maneuver it. Secondly, it is always required if you are doing a transplant sort of a thing over the macular hole, we should go bimanually because it becomes very difficult where you're using a light pipe and then you're trying to maneuver and then you start maneuvering with the light pipe. So you may damage the tissue as well, and it is very unhealthy. So always try to go bimanual in this. And I think in this particular case, it could be possibly a high myope because the hole was opened here and it was still, I think it was not
She's a
a
myope,
full
yeah.
retinal detachment. So we could have actually, I mean, whether
She's
it was the
already been
macular hole which
lasered
was
previously.
actually causing the recurrent RD,
Yeah.
or it was the primary, or maybe the retinotomy which was done. So that needs to be, I mean, encountered first.
The
because
retinotomy area was attached, the previous
yeah,
area,
so
and there
I
was
mean,
peripheral
we
laser
can
360
use.
degree was done.
I mean, we can where you have done a this thing. You could do a retinotomy or make it where the primary break is. So even if you close the hole, like I mean, in this condition, we are not aiming for visual success. We are mostly doing an anatomical closure of the hole.
Yeah.
That would prevent the recurrence of the RD. And we are not aiming for the visual improvement in this
Functional
sort of
improvement,
patients. So that is where we can use these graphs and all, or you can use an EMG in that condition.
So when you displace the graft from its harvesting site to the destined site, so is there any subfoveal fluid also
Yeah,
there?
so in this case, I have drained some fluid from the macular hole as well. Yeah, yeah. So in this case, so I've removed the fluid from there.
So we need to be dry it, right?
Yeah, yeah. it
Because
is-
sometimes
Otherwise,
the
it will
graft-
start
no, the
going
graft can
inside.
move
Yeah,
subretinally
yeah,
also.
yeah,
Sometimes that also
yeah,
happens.
yeah. It
Because
has
if
to
you
be
have a-
flat. Yeah,
You have to.
yeah. At that case, definitely.
No, no.
definitely.
I have used anterior capsule. I've done couple of cases where, again, I have used anterior capsule where I've mobilized it onto the surface. So PFCL, more or less, what he showed was like we can have slightly better advantage as compared to PFCL because maneuvering within the bubble of PFCL becomes slightly tricky. You know, it can slip and it can just go up.
No, no, you are
Yeah.
you are moving it with what?
No.
Island forceps or
Yeah,
integrate-
we tend to use it with island or we have a end gripping forceps sometimes.
I think best is by using DTMS.
No, once we,
But
this is
not
what
in
I
this
have, this is what the learning curve has been. Initially, I used to go with the light pipe and you're mobilizing it with the forceps. But now I have shifted to bimanual techniques when you're using, if you're putting a graft over the macular hole. Do it that way, it is very easy and it becomes much convenient to actually maneuver it over the macular hole because most of the times they get dislodged. As he said, he was showing with the oil also. So I think with the oil it doesn't float that much. You can, but then sometimes it happens. I've seen couple of videos of some other people where you are not able to find the graph where it has
Yeah.
dislodged. So and some people do stain the graph. I think with
gets-
BBG. Even I've seen one video where they have actually stained the graph with BBG so that they still know where the graft is in case if it
No,
floats
basically
out.
the graft.
Even if you identify that with the staining, but the anterior posterior flip is there, then that does not solve the problem.
I do not know because now our concern is just to close the macular hole to prevent the RD recurrence. We are not aiming for visual acuity
No,
improvement in that.
with this technique, all these things are covered.
Yes,
Yeah.
agree.
I've seen somebody was showing a video where they have to take the graft thrice because it kept getting sucked or getting lost. So,
Gets lost and gets entangled in the peripheral.
yeah,
cortex.
yeah. So
You
that's,
cannot find it.
yeah.
So partial FAE and moving the graft under that is the single take-home message from this very beautiful video.
And not using PFC.
Not using, obviously, not using this. Yes. Yes.
Cost.
Under PFCL, there is a risk of the graft getting out of the PFCL. It happens if we do not do the pinch. It's very similar to the peel pinch technique for the macular holes. So like in this case, when you made a hinge, you did not completely remove the... If you inject PFCL and under PFCL, if you take it to the macular hole, it would be exactly the same like under partial FAX. And then the chances of the flap coming out of the PFCL bubble would not exist. And in some cases, it...
The idea here is either that bubble should include the part where
Yeah, yeah,
that is
yeah.
what I'm saying.
Yeah.
Because once you're mobilizing it outside from the bubble into the bubble, that is where that you can feel that resistance, or that is where it may just go.
The point I'm trying to make is that without PFCL also you can do it.
Yeah,
And certain issues that you have with PFCL that can be avoided.
That was a wonderful video. when you are injecting the oil, you said you are holding the graft,
Yeah.
with your forceps. I think
I'm not holding, I'm just pushing it a bit with the closed forceps.
I think you can use viscot or something to
Yeah, that can be
inject,
done.
and
Yeah,
you don't need to hold it.
True, true.
It may be atraumatic.
Yeah, that can
That
be
was
done.
nice,
Yeah,
very
yeah.
nice. Very
Thank
nice.
you, thank you.